everyone, and welcome to the Multi-State Licensure Question and Answer session with NSGC's Director of Government Relations, John Richardson, brought to you by the Access and Service Delivery Committee's Licensure Subcommittee. My name is Jennifer Trotter, Senior Coordinator at NSGC. Before we get started, I have a few quick announcements. During today's presentation, all participants will be in listen-only mode. If you have any questions during the presentation, please use the chat feature located at the bottom of your screen. We will address questions submitted in advance first, but if you have any additional questions during the presentation, please use the chat feature to type your question at any time. Questions will be addressed after the presentation is complete. It is now my pleasure to introduce today's presenter, John Richardson. John currently serves as the Director of Government Relations for the National Society of Genetic Counselors. John's extensive knowledge of the healthcare system allows him to identify and successfully execute strategies to achieve advocacy goals for NSGC. John also provides guidance focusing on initiatives such as strategic planning, the development of practice guidelines, CPT coding, evidence-based research and outcome measures, and technologies that promote efficiencies within the administration of healthcare. John, thank you so much for taking the time to share about multi-state licensure today.
Thanks, Jennifer. Appreciate it, and also appreciate the Licensure Subcommittee for organizing this call. They have collected a lot of questions from you all, which is great, and I'm going to try to address the vast majority of them throughout the presentation. A lot of questions were very similar in nature, but the details were a bit nuanced, and really the answers and what you need to know is pretty straightforward, and so I'll try to address all of the issues that were raised. And if, as I'm presenting, if you have additional questions, as Jennifer said, just use the chat, and we'll try to answer them at the end of the presentation. Jennifer, can you actually go to next slide, because it's not allowing me to forward now. So right now, I wanted to quickly review the number of states that have licensure today and that are issuing licenses. So these are all the states that are currently issuing licenses. And so if you're delivering services in these states or into these states, and I'll get into those details in a little bit, you need to be licensed in these states. If you can go to the next slide. So these are the states that are currently remain in rulemaking. We expect many of these states to come online with their licensure in the not too distant future. Iowa is fairly close, and then the other work in Alabama, Arkansas, Georgia, Michigan are ramping up efforts in terms of drafting the rules and regulations that will actually implement the licensure laws. So I expect, within the year or so, all of those other states will have licensure available, with the exception of Hawaii. And Hawaii has been in rulemaking, it seems like, for a significant amount of time. I think there were some issues internally within the department that was making things difficult to get them finalized. I have heard recently that there's some movement there, so hopefully we'll start to see some draft rules coming out of Hawaii, but they certainly have taken quite a while. Normally, the effort to draft the rules and regulations is about a 1 to 2 year time frame. Ideally, it's about a year from start to finish, and I suspect that all Alabama, Arkansas, Georgia, Michigan will be similar. Iowa has taken a little bit longer as well. We had a little bit of a hitch up, but I think everything's in pretty good shape there. So in the next year or two, we'll be letting you know as these other states come online. Next slide. So this is kind of the core question, and I'm going to address it in 2 phases. So this is kind of, when do GCs need to be licensed? And then the second issue I'll address is the telemedicine issue. Obviously it's a big issue for many of you. That's why you are licensed in multiple states, is because you are delivering telemedicine services. So I'll address that in the next slide. But here, basically, you need to be licensed when you're providing a service that is defined as a genetic counselor service in the state law. So all of our legislation basically defines the scope of practice. And so if you're doing anything within that scope of practice, you need to be licensed. And obviously, we do receive a lot of nuanced questions, but the bottom line is if you're touching any part of that scope of practice, you have to be licensed. And so things like research, get a lot of questions about that. Well, I'm conducting research, can I be exempted? And the answer is no. And that's because if you're delivering clinical services, the whole key behind state licensure laws is to protect the public. And just because it's research doesn't mean that the public shouldn't be protected. And so you want to make sure that people are qualified that are providing these services when it is indeed part of that scope of practice. And so that's basically the bottom line, is that you really do need to be licensed if you're providing those clinical services. Now, there are some exceptions. Some states do contain some provisions that kind of speak to these allowable limited services. Sometimes it's like a time frame. You can't provide any more than 30 days worth of services. A lot of the times that provision is vague, and so you need to use your judgment in terms of whether you actually need to be licensed in those states. Right now, we do have a lot of resources. I think we can better define this allowable limited services in our Excel sheets, and we'll be doing that over the next couple weeks to a month, I think. So hopefully there'll be a little bit more definition around that. But some states do have these exceptions, which are a little bit different than reciprocity. Some of the states also have these reciprocity provisions, but they don't really, the bottom line is they don't really help alleviate any of the administrative or financial burden, because you generally need to still apply and become licensed. But so the allowable limited service would allow some of you to do some limited things in these states without becoming licensed. And so obviously the key issue is, if it's available in a state, you need to be licensed. Where you're practicing, where the patient is receiving the service, and I'll hit upon that next slide in much more detail. And then residency, also, it doesn't really take hold, so it doesn't really matter. So if you were living in New Hampshire, say, but practicing solely in Massachusetts, licensure is available in both states. You only need to be licensed in Massachusetts because that's where you're actually practicing. Now, if you were in Massachusetts as a New Hampshire resident, but you were delivering services through telemedicine into New Hampshire, you'd also need to be licensed in New Hampshire. So really, it's not about residency. It's kind of where you are when you're delivering that service and where the patient is receiving that service. If licensure is available in those states, you need to be licensed in those states. And that's pretty clear. The other thing, we got a few questions around, what happens if I'm delivering services into a foreign country? We're only talking about the United States. If you're in the U.S. delivering services into a foreign country, you should likely be aware of the rules and regulations and laws of those foreign countries. But generally speaking, they're not going to have much of a recourse to reach back to you in the United States. But so if you are delivering services into a foreign country and you're doing it on a fairly regular basis, I would definitely become aware of their local rules and regulations. But certainly U.S. law wouldn't bind you in any way to delivering those services when you are in those foreign countries, because our licensure and our licensure boards only apply to the state that's issuing those licenses, and that's pretty much primarily the reason why reciprocity generally doesn't work. States don't want to give up their jurisdiction to other states, because if their citizens are harmed, they want to be able to take action against those practitioners, and they don't want to have to rely on other states. And the only way that they're able to take action is if you as a practitioner are actually licensed in their state. And that's kind of the theory behind all of this, is that it's all kind of governed by local jurisdiction at the state level, and that's why states don't like to give up that jurisdiction, because if their citizens are harmed, if the individual who committed that harm isn't licensed in their state, there's little recourse they can take. Okay, so you can go to the next slide. So for telemedicine, again, this is the basic rule of thumb. If you're a counselor and you're practicing in a state, so you're delivering services from a site, and that location is in a state with licensure, you need to be licensed in that state. The other thing is you need to consider where the patient is when they're receiving the service. And so again, it doesn't matter if the patient is a resident of a certain state, it really matters where the patient is, their physical location when they receive that service. And so like we got a couple questions from, some of you have a clinic that may be seeing patients and they're traveling from different states. Do I need to be licensed in those states where the patient's a resident? And the answer is no. So long as you're licensed in the state where you are physically delivering that service to that patient, that's all that's required. And so it really is, the controlling factor is where you are, where the patient is, and is licensure available. The other issue with telemedicine, just to be aware of, is that states do have separate requirements for delivering telemedicine services. Most of the time, these regulations are outside licensure requirements in terms of the actual Licensure Act for you or for any other practitioner. So generally speaking, like the Medical Practice Act that binds physicians in terms of their practice, they don't have telemedicine rules and regulations under their Practice Act. They're usually a separate law within the state. And so sometimes the telemedicine law applies to all healthcare practitioners broadly. Sometimes they may only apply to specific practitioners. And so it's also a good idea to be familiar with whatever state requirements there are for telemedicine, and generally speaking, it's defining technology. And so can you just use a telephone, or do you need additional technology where you can actually see the patient and they can see you, so the visual aids and all of that. These requirements are very difficult to keep track of because states are always changing these requirements, which makes it pretty complex. But the ATA does have a website. I listed it on the presentation here. They are a good resource, but I'll say that even they admit that their information may not be up to date, and they're the sole organization that really follows this stuff. So they're a good resource and a place to start when you're trying to figure this out. Generally speaking, you're going to be okay delivering these services via the phone. The key thing is to make sure you're licensed. Next slide, please. So the other issue to keep in mind is whether the actual scope of practice allows you to order tests. So I kind of went through and listed out the states that allow you to order. Generally speaking, labs are going to want you to put a referring physician's name on the test requisition along with your name. Generally speaking, you'll receive results and the referring physician will receive results as well. And this kind of stems from another state regulation that regulates laboratories, and that's New York State, which actually requires a physician signature to be on all requisitions, regardless of who's ordering it. So generally speaking, you'll find that to be the case, that you have to list the physician that's referred the patient as well. You can go to the next slide. So a few states allow genetic counselors to order, but with only a practice agreement in place. And so it's a little level of supervision where you have to have a formal agreement with a physician that they're available to consult from time to time. It's not a very high level of supervision. It's really just an agreement that you have a resource that you can check in with if you need to utilize that resource. And those 3 states have those provisions. I think that there'll be a move to actually potentially do away with these practice agreements. From what I've heard is physicians just feel like it's another layer of paperwork. And so Washington and Ohio were states that really were on the front end of having the ability to order tests. And at the time, it was really the only way we were going to allow genetic counselors to order because medical societies weren't completely comfortable with that. Nowadays, medical societies, I think, are much more comfortable with allowing counselors to order, and so it's easier to allow the ability for you to order to these licensure laws today than it ever has been. But still, some states will push back. Alabama was a good example this year where we just couldn't add it to the scope of practice because the medical society would not have supported the bill. So we try and add it whenever we can, and we're actually going back to some states where we haven't been able to, and you can go to the next slide because there is one state in particular that explicitly doesn't allow a genetic counselor to order, and that's Pennsylvania. And so there's actually a bill in the works that would allow counselors to actually order in Pennsylvania, and we've had I think that is likely to happen. If not this year, but next year, hopefully. So again, we try to allow genetic counselors to have the most flexibility in terms of how they practice, and this is one area where we'll continue to put a lot of effort into is the ability to order tests. So the states that aren't listed out here, they generally will use, again, some kind of vague language that talks about identifying and coordinating genetic tests. So you should really work with your compliance people to see how they interpret that. I can argue both ways, that it allows you to order and it doesn't allow you to order. So I think there are people in some states under those scenarios who are ordering, and then there are some others where they're at an institution that's super conservative in terms of the way they interpret law, and they're not able to. So it kind of is a institution by institution, employer situation. You can go to the next slide. So this has gained a lot of attention, or more attention, I'd say. And so there's quite a long story behind the Interstate Licensure Compacts for physicians. But essentially, there is an interstate licensure, physician licensure compact today. It does allow, so a lot of you obviously feel the administrative burden and the financial burden of becoming licensed in multiple states. And we certainly understand those burdens, and we do try to lessen them. I mean, our state laws are quite similar, even though there's these weird kind of provisions that every, individual state seems to have. We do make the laws actually more alike than what other practitioners actually experience. I think the counseling profession is lucky in that you have one certification that really is the gold standard, and so you find other practitioners that have competing certifications, multiple certifications, and then the requirements, the base requirement for licensure gets really complex. In some states you might have to be certified by 2 different bodies, and others you wouldn't need to be certified at all. So it gets pretty complicated. But so with this Physician Licensure Compact, it provides an expedited pathway for licensure if you're considered a qualified physician and you're practicing in multiple states. So qualified physicians into the compact would be people who basically have, a complete stellar record. No complaints have ever been filed against them. That sort of thing. They've been proven to provide high quality care. So they have been working on this for about 50 years. So physicians have been regulated since about the mid-1960s. And so the compact has been discussed over the past 50 years. It never really got off the ground until about 2013, and at which point the Federation of State Medical Boards came up with draft model legislation that could be utilized at the state level that would create a compact. I actually was involved and provided comments back to the FSMB, working for a different group who's focused on licensure and credentialing issues. And so I'm very familiar with the process and was actually behind the scenes working on it, back in 2013, 2014. So basically, what the compact allows is for this expedited process, but it actually is more expensive because you actually got to pay the compact fees in addition to your licensure fees. So it really doesn't address the financial burden, but it does address the administrative burden. And that is basically physicians have to apply for their initial license. So when they first start to practice, they need to apply for an initial license. And that is the regular kind of process of getting approved. And so that process can take, weeks to usually it's months for physicians to get approved in terms of that licensure. Then once they become approved, that becomes kind of their home state, and then they're able to subsequently apply to additional states, and that application process is much easier. They basically have to fill out an additional application, but once that application is complete, all they need to do is update it with updated information around GME and that type of thing. So applying to these additional states and renewing for these additional states is an easier task than it was otherwise. 22 states have joined thus far. 6 states have enacted laws, but they haven't implemented, and some of those states are having trouble actually implementing. But so if you're practicing in those 22 states and you want to join the compact, then it is an easier expedited process. Now, physicians are the only real group that have had success in trying to do this. And again, the challenge has always been that states don't want to give up jurisdiction to other states. And so they hold on to their jurisdiction and they want to issue their individual licenses themselves and not cede any power. This actually allows each of the medical boards to maintain pretty much their authority and power, so they're not ceding any jurisdiction to other states. It makes a lot of sense. Nurses have had trouble trying to do something similar. There is a renewed effort on the nursing side to do this. And it's something that obviously we've kept our eyes on for quite a while. I think that we're getting to the point where we can start to have more serious conversations around this. If we tried to put a compact-like provision in our licensure bills from the get-go, we would have probably never been successful with enacting any of the licensure laws. Again, because of this jurisdiction issue, states would have kind of run away and gotten worried that they wouldn't have the power to protect their citizens. So now we're approaching 30 states. I think we can have a serious conversation. One thing that we have in our favor is that many of you are actually licensed under the medical board, so the vast majority of states are. It may be possible to actually just amend these compact laws to have you included under this law and create basically a genetic counselor compact. We've kind of had a brief conversation with the compact about these things, and I think there could be some interest there in investigating it further. But this is something that we'll definitely be looking at in the future. And again, I think it could help immensely on the administrative side. It probably won't on the financial side. again, the compact was created really for telemedicine. You have a lot of imaging that's occurring through telemedicine, and so imaging, whether it's cardiac care, whether it's orthopedic care, what have you. A lot of hospitals are basically utilizing telemed, particularly in rural areas, and then other more smaller community-based hospitals that can't have people on staff in the hospital 24/7, but they have emergency departments that are open 24/7, so they utilize these services. And so you have a lot of teleradiology and imaging services that are delivered, and that was really the driver of all of this. It was so that physicians could quickly become licensed, credentialed, and then bill for their services. So that's the major driver behind the Interstate Compact, and something, like I said, we'll be investigating as more and more states enact licensure laws. And I hope that that the physicians have done the heavy lifting, and that the medical boards will be comfortable with these arrangements, and that we won't necessarily have to fight the battles that were fought, and it'll be an easier path forward, is what I'm hoping for. Next slide. So in terms of the compliance, as I said, a lot of the questions we received are nuanced, but the bottom line are kind of those fundamental principles that I outlined in the first couple slides. But you're responsible for making sure that you are compliant in your practice. Certainly, your employer should have resources available to you, because it's also their responsibility. So, many employers will have compliance officers, general counsel. I am aware of sometimes that counselors reach out to these folks and they interpret the law in a way that the genetic counselors disagree with that interpretation. I think that in those cases, reach out to us, the licensure subcommittee, if you're being frustrated in those ways. And maybe we can put our heads together and create a strategy or some talking points that would make whoever's providing the advice that you may think is bad advice, maybe we can kind of educate and open up their eyes to think a little bit differently. We have definitely seen that occur in the past, where you had compliance folks or general counsel who really didn't understand genetic counseling, genetic counselors, the actual requirements for licensure. Some will look at a law and they'll say, well, you have to be supervised by a physician. That's just complete nonsense. So, and we can create talking points that'll help educate in all of that. So, we do have a lot of resources. I think that we have great documents. We have some Excel documents that kind of outline the renewal process, what's required for, initial licensing, renewals by the individual states. So the licensure subcommittee has done a lot of work on those resources, and I would really let you know that those things should be utilized whenever you have questions, and then you can also reach out to us. So with that, I think that's the final slide. I think we can take questions. Jennifer.
All right, thank you so much. So yeah, the first question we have is, how does the federal Medicare bill impact licensure?
Yeah, it's a good question. In reality, it really doesn't impact licensure, and licensure doesn't impact the federal bill. Some people talk about the federal Medicare bill as national licensure, and it really isn't that. So basically, under Medicare today, if you're practicing in a state with licensure, you're considered an independent practitioner. But for Medicare beneficiaries, you can't practice that way. So because you're not recognized under Medicare, you have to practice under the supervision of a physician. Obviously, that creates inefficient delivery models. And so if the Medicare bill is enacted, what Medicare policy is the foundation of Medicare policy is state regulation. So if you're a nurse practitioner, if you're an audiologist, if you're a physician, you're a recognized Medicare practitioner, you basically are practicing according to your state scope of practice. So it's whatever your state allows you to do, you could do for Medicare beneficiaries. And so if the law is enacted, you're in a state where you can order a genetic test, you'd be allowed to order a genetic test for a Medicare beneficiary. Now, if you're in a state without licensure and the bill is enacted, there's a special provision in the legislation that dictates that the Secretary of HHS will determine in those states who can practice, so the requirements to be a genetic counselor and the scope of practice. We believe that the Secretary will look at the profession and say that you need to be ABGC certified in order to provide services to Medicare beneficiaries in those states without licensure. And so they will also create a scope of practice. Now that scope of practice is likely not to be as open as what the state scope of practices currently are. Like I would be surprised if the Secretary would allow you to order a genetic test, for instance. And so that's basically the relationship between the federal bill and state licensure. The federal bill would allow you to become recognized Medicare practitioners, so you can basically practice and deliver services to a Medicare beneficiary just as you would a non-Medicare beneficiary today. So it should harmonize the delivery model in which you're using, and hopefully if you are like a hospital or a physician practice-based counselor, you'd be able to provide services as independent. So you can receive referrals from a multiple referral base and see patients and provide the genetic counseling and then send them back to the referring practitioner if the medical follow-up is required.
All right, next question is there a way to influence previous or future licensure bills or the rules and regs process to make licensure easier for GCs to obtain, especially for GCs with multiple prior licenses?
In terms of the process, I mean, the compact could help. All of our licensure laws basically allow the body who will be issuing the licenses, so usually it's the medical board, to develop the application. And unfortunately, the states all have their own individual processes. They all kind of have their own individual kind of one-off requirements. And so it's very difficult to make these applications all the same just because you have so many different entities that already have built-in processes that are developing the application. We certainly push back when we see requirements on an application that either really aren't relevant to the profession or aren't authorized by law. So in other words, the underlying Genetic Counselor Licensure Act didn't really require it or speak to it. So we push back quite a bit when we see those types of things to lessen the burden. And I'll say we've been pretty successful in that, even though many of you who are filling out these applications probably don't appreciate that because it's still a burden. But we do try to lessen it as much as we can, and we do work with regulators as they develop the applications and certainly the rules and regulations, and we make sure that they don't go above and beyond what the law required, And like Iowa is a good example where we believed the regulators were going well beyond what was required under the law, and we worked with them to kind of solve that problem, so it's not going to be as burdensome as it would have been.
Thanks. The next one is, what options exist to manage licensure renewals? Is NSGC tracking this?
I mean, we have a Excel sheet that kind of lays out, you know, when renewals are required. You know, some states use, you know, even years, odd years, birth dates. It varies from state to state, but we do have an Excel sheet that pretty much lays all of those requirements out. In terms of you as an individual tracking all of that, you know, there are some resources out there. There's some software resources. If you Google, you know, licensure, credentialing, tracking, technology stuff, like a search like that, you're likely to find some resources that are out there. Now, again, if you're working for a larger employer, they may internally be able to help you track those things because they have software that certainly is keeping track of when licensure is expiring for medical staff, and also credentialing and recredentialing. So, you know, a lot of the times if you're working at an institution with a medical staff office, they might be able to help you. If they're not able to help you, they might be able to really direct you to a resource that could help with that.
Thanks. Somebody in the chat box just said meetelsie.com is the software specifically for genetic counselors to track renewals. And then also Melanie Hardy, who is the vice chair of the licensure subcommittee, let me know that the multi-state licensure group is working on finalizing the resources for applications and renewal for each state, and we're going to be putting those on the website shortly. So,
and I think that'll help. I think these Excel sheets are going to help tremendously. There's a lot of great information, and I know that licensure subcommittee. I mean, these things do change without notice a lot of the time, and so I think if we can all work together once we publish the Excel sheets, and if you see something that has changed, certainly reach out to us so we can make the change in our resources.
So the next question is, if a genetic counselor strongly suspects a laboratory of participating in Medicare fraud, what is the responsibility or potential liability of reporting this activity to the Office of Inspector General?
Yeah, so I mean, there are whistleblower protections. Obviously, we've seen an increase in what I would say suspect activity, and I'll also go on to say I think we've seen activity that's out and out just fraud. Obviously, the OIG put out an alert regarding some of the fraud that was taking place in kind of the genetic testing space. You know, I think some of it was just completely fraudulent. I think that there are some entities out there that were just trying to collect beneficiary Medicare numbers, and how they were using them is probably going to come to light through some of the OIG investigations. But so if you suspect that you see something going on that you don't think is appropriate, you should report it. And you know, we've put out all the links to the OIG's website. It's easy. Google just HHS OIG, and they have a pretty robust web page that allows you to report. It provides you with some additional information, and there are whistleblower protections. And I will also say that if you're a whistleblower and that fraud is detected and HHS takes action, and there are fines levied, that you know, whistleblowers benefit from whatever's collected from HHS. So You know, there are whistleblowers out there that are basically that's their full-time job, and they uncover waste, fraud, and they get reimbursed for that work. So if you see something, whistleblowers are generally protected, and you should report it. And I think that, you know, it was great with this latest round of these pop-up labs and some of the other stuff that was going on. I mean, they were hiring insurance salespeople to do cheek swabs. There were just all sorts of things that seemed really dodgy. And I think it was genetic counselors who actually reached out to the OIG, and it really did bring their attention to the issue. And that's why they put out the alert. It's because there were a lot of counselors out there that did just that and blew the whistle. I was actually in a congressional office 2 weeks ago, and I received a question from a staffer who had been contacted by an insurance salesman who had been contacted by, quote unquote, a genetic laboratory who wanted them to start actually going door to door to sell insurance, but really to get cheek swabs and sell this free genetic test, which probably didn't exist. But so, you know, Congress is more focused on the fraud issue in the genetic space, and I think HHS is too.
All right, so I'm going to try and start taking questions from the chat. We've been getting a lot, so thank you all for submitting your questions. We might not be able to get through all of them, but here goes. So the first one is, how is delivering services defined in the context of licensing? Our team of GCs work for an insurance company where we do not provide clinical care to patients, but we do review requests for genetic test coverage for our members all over the US. Do we only have to be licensed in the state in which we physically work, or in additional states as well?
Yeah, I mean, this is a perfect example of a question for your compliance office. And if you're working for a health plan, you have a big general counsel's office in compliance, I think. So yeah, I mean, it really depends on the details of the services that you're providing. If you're providing services and working, you know, say in the lab space, looking at test requisitions, those requisitions are coming from out of state, but you're not really doing anything other than reviewing, working where the lab is. You know, I think you don't need to be licensed in those other states. Just be licensed where you're working. If you're consulting with other physicians about which test to order, that's probably a different story, and that may trigger you know, you being licensed wherever that person you're consulting with is. But you know, these are the nuances where I really I can't give you the exact answer. You really need to work on that with the compliance people.
Okay, thanks. Yeah, we got a couple of questions about ordering as well, so this might fall into the same category, but so one was, for ordering tests, does that apply to the state where the patient lives or where the GC is practicing? For example, for telemedicine, can a genetic counsel order a test for patients living in those states? And then also, different question, but along the same lines in terms of regulations. If I'm a genetic counselor in Illinois, that allows for ordering of genetic testing, counseling a patient in Pennsylvania, which does not allow ordering of genetic testing, can I order testing?
Yeah. So the first question would be essentially, it's where you are when you deliver the service. So if you were, let's take Illinois. If you're in Illinois, the patient's coming from Indiana, you just need to be licensed in Illinois, and because Illinois allows it, you can order the test. Now, if the patient is in another state that doesn't, like Pennsylvania, that doesn't allow ordering, that's when you should look back to the telemedicine laws. If Pennsylvania, and I'm not an expert on each and every state, if Pennsylvania had a law that basically said in terms of delivering telemedicine services, you need to abide by the scope of practice of Pennsylvania, then you wouldn't be able to order that test, even though Illinois does. Maybe the state where the patient is allows you to practice utilizing your, what I'll call your home state license and scope of practice. And so, again, these are nuances, but generally speaking, you would need to follow the scope where the patient is. That's generally the rule of thumb. So again, it wouldn't be where you are, it's where the patient is and what that scope of practice allows.
All right, going back to the federal bill, somebody asked, why does the bill.gov show a 3% chance of a federal bill passing?
What was the beginning of that? Sorry.
Sorry, the website bill.gov shows a 3% chance of the federal bill passing. I just want to know why it's so low, I'm guessing.
I don't know. I don't pay any attention to that. I mean, a website doesn't know the politics of what's going on. And so maybe looking at the co-sponsorship. So we're just starting to build co-sponsors. That's probably what it is. I bet you. I'm not trying to do the math in my head, but yeah, no, it's probably based on co-sponsors, which sometimes can be a good barometer of whether a bill moves. I think that with all of you helping and reaching out to your member of Congress, we'll build the co-sponsorship up. Now, Congress is out for 6 weeks. They come back the second week of September, and we've been doing a lot of meetings, and I know a lot of you have been doing a lot of outreach. And so I think in September we'll start to see the co-sponsorship list grow once they're back in session, and the Washington, D.C. staff have a chance to kind of meet face-to-face with their bosses. That's when the decisions usually are made, is when they are face-to-face and not when the boss is off in the congressional district. So I think we'll see that steadily build. If you want to become a member of our Key Contact Network, which are individuals who will have a little bit more personal contact with individual staff members of the members of Congress, you can go to advocacy@nsgc.org and sign up. If you'd like us to help arrange a meeting with your member of Congress, we're able to do that. Again, you can go to that website, the email address, advocacy@nsgc.gov. But in terms of websites and averages like that, I don't think they're meaningless. We could have 0 co-sponsors, but it's a priority of the Speaker of the House. I mean, the bill gets enacted. So yeah, I think we're in pretty good shape. It is a process, and we're early on in that process. We haven't heard any opposition to date, so that's great. Usually, we'd hear about concerns. We haven't really heard of any concerns, so all positive stuff, and hopefully we'll get it done. In the late fall, there's likely to be some healthcare vehicles that will move. Again, there's almost 0 chance the bill will move as a standalone piece of legislation. The legislation will probably be packaged into another legislative vehicle and move as a big omnibus bill, and something like that might move in the late fall, early winter. So that's kind of what we're geared up for. Also, I will say we do have this group sign-on letter for organizations to sign. We'll be communicating with the general membership probably next week about this. But if you do work for an organization, we're asking organizations to sign this letter. So we'll have patient advocacy groups, we'll have hospitals, we'll have health plans, we'll have laboratories. Certainly the telemedicine companies informed DNA has already signed the letter. So we'll have groups like that signing this letter, and it'll be delivered to Congress in September when they get back. So that's something we're working on in the near future.
Okay, and we've gotten a few questions about returning results of genetic tests to patients. So just to clarify if the rules are any different for that. So if patients have to call back in to get the results, does the GC need to be licensed in the state that the patient is calling from?
Are you good?
Yes. Yeah. So I mean, returning results would be within the scope of practice, and so whenever you're doing anything that touches upon that scope of practice, and licensure is available in the state where the patient is, then you should be licensed.
Okay, I think that pretty much covers it. So if you did have a question that we didn't get to today, please feel free to email it to me at jtrotter@nsgc.org, and we will do our best to get back to you. Like I said, also we're updating the resources on the NSGC website, so stay tuned for that.
So I'll just confirm that we'll be starting.
Thank you, everyone. And as Jennifer said, if you have any questions, please feel free to reach out to us.
Thank you. Bye.